Hi everybody, and welcome to our module on phenylalanine and tyrosine. In this module we're going to focus in on two amino acids, phenylalanine and tyrosine. And the reason these two amino acids are so important is because they're involved in several different metabolic pathways, and in addition there are a couple of different metabolic disorders that result from deficient metabolism of phenylalanine and tyrosine. So these are important amino acids for the synthesis of several neurotransmitters including dopamine, norepinephrine, and epinephrine. They're also used in the pathway by which we synthesize thyroid hormone and melanin. Their metabolism involves several important vitamins and cofactors, which we'll discuss in this module. And then finally, there are three metabolic disorders that involve metabolism of phenylalanine and tyrosine, and those are phenylketonuria, albinism, and alkaptonuria. Phenylalanine gets its name because its molecular structure is the same as alanine with a phenyl group added. This is the structure of alanine on the left side of the screen, and on the right is the structure of phenylalanine, and the difference is the addition of this phenyl group right here. Phenylalanine is an essential amino acid. You must consume it in your diet. The body cannot synthesize it de novo. And the first step in phenylalanine metabolism is to convert it to the amino acid tyrosine. And this is an easy way to remember that tyrosine is therefore non-essential because it can be derived from phenylalanine. The enzyme that converts phenylalanine to tyrosine is called phenylalanine hydroxylase, and its job is to add an hydroxyl group, an OH group, to phenylalanine. The difference between tyrosine and phenylalanine is the addition of this OH group right here. And phenylalanine hydroxylase requires a cofactor called tetrahydrobiopterin, and let's talk about that now. So tetrahydrobiopterin is often called BH4. It is a cofactor for phenylalanine metabolism into tyrosine. This is the structure of tetrahydrobiopterin on the screen here, and it will be converted into a molecule of dihydrobiopterin, or BH2, and in the process it will convert phenylalanine into tyrosine. What happens is the molecule loses a hydrogen at this nitrogen group here and another hydrogen here, and as a result we end up with a double bond in dihydrobiopterin. Now you need to regenerate BH4 in order to continue metabolizing phenylalanine, and that is done using an enzyme called dihydropteridine reductase and a molecule of NADH, which is converted into NAD. So putting this all together, phenylalanine is converted to tyrosine by phenylalanine hydroxylase. In doing so, it converts a molecule of BH4 into BH2, and then the BH4 is regenerated by dihydropteridine reductase using molecules of NADH. If you are deficient in the enzyme phenylalanine hydroxylase, you will be unable to effectively convert phenylalanine into tyrosine, and that will cause a condition called phenylketonuria, which is often abbreviated PKU. This classically results from a defective enzyme phenylalanine hydroxylase. That's called classic PKU. You can also develop this if you have a defective or deficient BH4 cofactor. We'll talk more about that in a minute. This is the most common inborn error of metabolism in humans. It results in the accumulation of phenylalanine, and in addition there is a deficiency of tyrosine because you are not able to effectively synthesize tyrosine from phenylalanine. Now sometimes when you measure tyrosine levels in babies who have PKU, it will be low normal, and that's because there is such a high level of phenylalanine that you are generating some conversion to tyrosine, but you will not have the level of tyrosine that you should have to match the high level of phenylalanine if you are deficient in the activity of this enzyme. The reason this is such a serious disorder is because when phenylalanine cannot be converted to tyrosine, it will be metabolized through alternative pathways. This will create metabolites which are toxic to children born with this condition. So there are alternative pathways for phenylalanine metabolism that result in the formation of substances called phenylketones. This is how this disorder gets its name. These phenylketones appear in the urine, hence the name phenylketonuria. And phenylketones include substances like phenylpyruvate, phenylactate, and phenylacetate, and these are all toxic to children who are born with a condition of PKU. A classic symptom of phenylketonuria is a musty smell in the urine. This comes from those phenylketones. They have a smell when they are present in the urine. In addition, babies born with this condition have CNS symptoms. They often have mental retardation. They can have seizures and they can have tremor. And then finally, these babies classically have pale skin and fair hair and blue eyes, and this is because they lack melanin. Melanin is synthesized from tyrosine, and these babies have poor synthesis of tyrosine because they cannot convert the phenylalanine into tyrosine. The way you treat phenylketonuria is through dietary modification. You restrict phenylalanine in the diet of children born with PKU. Now, unfortunately, phenylalanine is found in most proteins. It's an essential amino acid. So there are synthetic amino acid mixtures which are made just for children with PKU. You can actually monitor a phenylalanine level in the plasma of children with PKU to make sure they're not getting too much in the diet. In addition, these children have to avoid the artificial sweetener aspartame, which is found in Equal and NutraSweet. This is the structure of aspartame on the screen here, and it contains the amino acid aspartate linked to the amino acid phenylalanine. This is the phenylalanine over here. So if babies with this condition consume artificial sweeteners like aspartame, they will be consuming phenylalanine, which is bad for their condition. And then finally, another dietary modification you have to make is to consume tyrosine. It becomes an essential amino acid because you cannot synthesize it from phenylalanine when you're deficient in the enzyme. Maternal phenylketonuria is something that happens to women who have PKU and then become pregnant and consume too much phenylalanine. This has nothing to do with the fetus or the baby having PKU. It has to do with the mom having PKU and then eating too much phenylalanine while she's pregnant. The high levels of phenylalanine in the mother will act as a teratogen to the fetus, so the baby can be born with microcephaly and congenital heart defects. So women who have PKU have to have their phenylalanine levels carefully monitored while they are pregnant so that the baby doesn't develop birth defects. You can screen newborn babies by measuring a phenylalanine level. If you're going to do this, you need to wait until about 2 to 3 days after birth. That's because maternal enzymes may normalize the levels at birth, but after a few days, the baby has to start metabolizing it on its own. So a phenylalanine level after 2 to 3 days will represent the baby's ability to metabolize this amino acid. As I said before, classic PKU comes from deficiency of the enzyme phenylalanine hydroxylase, but you can also develop it from a deficiency of the BH4 cofactor. This is rare. It only represents about 2% of cases of PKU, and it results from defective cofactor BH4. It's often due to a defective enzyme, dihydropteridine reductase. Recall that that is the enzyme that regenerates BH4 so that it can convert phenylalanine into tyrosine. You can also sometimes develop this from an impaired BH4 synthesis metabolic pathway. The findings in this variant of phenylketonuria are similar to classic PKU in that you have elevated phenylalanine and all the things that go along with that. But in addition, BH4 is an important cofactor for the synthesis of several neurotransmitters, which we'll talk about later in this module. These include epinephrine and norepinephrine, also serotonin, and finally dopamine. And the reason I've bolded dopamine is because dopamine is very important in the hypothalamus, which I've shown on the screen here. Dopamine inhibits prolactin secretion, and therefore when you are deficient in dopamine from a BH4 deficiency, you can see high prolactin levels. And in fact, prolactin levels are often monitored in children who have this condition to determine how much dopamine is working in their body. The treatment is similar to classic PKU in that you need to restrict phenylalanine in the diet, but in addition, you need to supplement with the BH4 cofactor. Children with this variant of the condition are also administered L-Dopa carbidopa. This is a Parkinson's drug. It can result in increased dopamine levels in the CNS. We're going to talk more about this later in this module. And then finally, children with this variant of PKU often take 5-hydroxytryptophan, which is a precursor of serotonin and can help to boost the serotonin levels. Now that we've talked about the metabolism of phenylalanine into tyrosine, let's talk about the metabolism of tyrosine. This is the structure of the amino acid tyrosine on the bottom of the screen here, and you can see that it has a very similar molecular structure to several compounds, including dopamine, norepinephrine, and epinephrine. And now we're going to talk about how tyrosine is converted into these three hormones. The first step in the metabolism of tyrosine is synthesis of a molecule of dihydroxyphenylalanine, or DOPA. DOPA differs from tyrosine only by the addition of a hydroxyl group, as I've circled right here. From DOPA, you can synthesize a molecule of dopamine by removal of the carboxylic acid group at the end of the molecule. Dopamine can be converted into norepinephrine by addition of a hydroxyl group. And then finally, from norepinephrine, you can synthesize epinephrine by addition of one methyl group to the end of the molecule. So you can see that one structure on the screen here differs from another by a slight change to the underlying molecule. And in the next few slides of this module, we'll zoom in on each step of this process and talk about the enzymes that catalyze each conversion. The first step in metabolism of tyrosine is conversion to a molecule of dihydroxyphenylalanine, or DOPA. The enzyme that does this is called tyrosine hydroxylase. It adds an hydroxyl group to the 6-member ring, and just like phenylalanine hydroxylase, tyrosine hydroxylase also requires the cofactor BH4 or tetrahydrobiopterin. And just like we saw with phenylalanine hydroxylase, this BH4 molecule must be regenerated via the action of dihydropteridine reductase using NADH. There is a very old antihypertensive medication called mettyrosine that's not used anymore that inhibits tyrosine hydroxylase. This blunts the conversion of tyrosine to DOPA and therefore blunts the synthesis of norepinephrine and epinephrine. That's why it was effective as an antihypertensive. It is sometimes used in pheochromocytoma when you want to shut down production of catecholamines. The next step in tyrosine metabolism is to convert the molecule of dihydroxyphenylalanine or DOPA into dopamine. This involves removal of the carboxylic acid group from the end of the DOPA molecule, and the enzyme that catalyzes this step is appropriately called DOPA decarboxylase. And just like many other decarboxylase enzymes, this requires vitamin B6 as a cofactor. And there's an important clinical correlation of this step, and that involves the drug carbidopa, which is used to boost dopamine levels in patients who have Parkinson's disease. So let's talk about the combination therapy levodopa-carbidopa, which is sold under the trade name Sinemet and is given to patients with Parkinson's disease. The problem in Parkinson's disease is that the levels of dopamine inside the basal ganglia are too low, so you want to administer drugs to boost those levels to relieve symptoms. This is the structure of L-DOPA on the left side of the screen here. It's the same structure as the molecule I've been calling DOPA on the last few slides. It's called L-DOPA because it's in the L configuration, but that's the same configuration found in the body, so this is the same molecule as the one I've been describing as DOPA on the last few slides. You can administer L-DOPA to patients with Parkinson's disease, and it can cross the blood-brain barrier and be converted by DOPA decarboxylase inside the central nervous system into dopamine, and this can boost dopamine levels inside the basal ganglia. This sounds wonderful, but the problem is that there is a peripheral DOPA decarboxylase which can convert DOPA into dopamine peripherally, and the peripheral dopamine cannot cross the blood-brain barrier. In addition, the peripheral dopamine gives lots of side effects like tachycardia that make patients feel unwell. So concomitantly with the L-DOPA medication, a drug called carbidopa is given, which is an inhibitor of DOPA decarboxylase. Its job is to inhibit the peripheral conversion of L-DOPA into dopamine so that more of the L-DOPA can cross the blood-brain barrier and be converted to dopamine inside the central nervous system. And as I told you before, vitamin B6 is a cofactor for DOPA decarboxylase, so patients taking Sinemet for Parkinson's are advised not to take high levels of B6 because it can activate the peripheral decarboxylase enzyme and result in more conversion to dopamine peripherally. The next step in tyrosine metabolism is the conversion of dopamine into a molecule of norepinephrine. This involves addition of a hydroxyl group to dopamine. This is catalyzed by the enzyme dopamine beta hydroxylase, and this enzyme requires vitamin C as a cofactor. This is a very unusual reaction for vitamin C. Mostly when you think of vitamin C, you should think of the synthesis of collagen, but one other place it plays a role is in this reaction shown on the screen. The next step in tyrosine metabolism is conversion of norepinephrine into epinephrine. This involves addition of a methyl group to the end of the molecule of norepinephrine. The enzyme that catalyzes this step is called phenylethanolamine N-methyltransferase, which is a mouthful to say, and it requires a very important cofactor called S-adenosylmethionine or SAM, and that's what we're going to talk about in the next few slides. So S-adenosylmethionine or SAM is a cofactor that donates methyl groups, and it is synthesized from ATP and the amino acid methionine. This is the structure of methionine, and this is the structure of ATP. And if you lop off these phosphate groups right here and you attach the sulfur group to the adenosine molecule, you will end up with a molecule of SAM. You can see that it has this methyl group hanging out here in space, ready to be plucked off the molecule and donated to other structures. And that's the purpose that SAM serves in a number of reactions, including the synthesis of epinephrine. It's very important to know that the amino acids methionine and homocysteine have very similar structures. This is methionine on the left side of the screen here, and this is homocysteine. The only difference is that homocysteine has lost this methyl group right here. This means that once the methyl group is donated from SAM, you will be left with a molecule of homocysteine. I've shown that on the screen here. If you take a molecule of SAM and you remove the methyl group and then you remove the adenosine nucleoside, you will be left with a molecule of homocysteine, and thus homocysteine is produced by reactions that take a methyl group from SAM. So putting it all together, if we go back to our conversion of norepinephrine into epinephrine, which involves addition of this methyl group to the molecule of norepinephrine, that methyl group comes from SAM. It's this one right here. And once we give that methyl group to norepinephrine and synthesize epinephrine and we remove adenosine, we will be left with a molecule of the amino acid homocysteine. Now you need to regenerate methionine in order to maintain levels of SAM inside of cells and continue metabolizing norepinephrine into epinephrine. And to regenerate methionine, you need the vitamins folate and B12. The pathway looks like what I've shown on the screen here. Folate is converted to N5-methyl tetrahydrofolate. A molecule of N5-methyl tetrahydrofolate plus a molecule of homocysteine can be converted into tetrahydrofolate and methionine, and the methionine can then go and make more SAM. And this conversion requires the vitamin B12. So back to our big picture slide, we can convert a molecule of norepinephrine into epinephrine by the addition of a methyl group to the end of norepinephrine. That methyl group comes from this position on a molecule of SAM, and if we remove the adenosine, we will be left with the amino acid homocysteine. Using the vitamins B12 and folate, homocysteine can be used to regenerate methionine, and then methionine plus ATP can be used to regenerate SAM. And in another module, I will talk about the amino acid homocysteine, but you can already see from this picture that if you are deficient in B12 or folate, you will end up with elevated levels of homocysteine. And indeed, one of the causes of high homocysteine levels is a deficiency of either of these two vitamins right here. So if we go back to the pathway of tyrosine metabolism, we talked about how tyrosine was converted to DOPA, and that required the cofactor tetrahydrobiopterin. DOPA was converted to dopamine, requiring the cofactor vitamin B6. Dopamine goes to norepinephrine, and that's the unusual use of the vitamin C. And then finally, norepinephrine can be converted to epinephrine using the cofactor S-adenosylmethionine. Now let's talk about some other compounds that can be derived from tyrosine. You should know that the thyroid hormone thyroxine, or T4, is derived from tyrosine. This is a multi-step process. It involves the addition of iodine, which is very important in thyroid hormone, but the final product is thyroxine, or T4, and it comes from the amino acid tyrosine. Melanin is another compound that is derived from tyrosine. Melanin is the pigment that gives color to your skin, your hair, and your eyes, and it is synthesized by cells called melanocytes. And melanin is a polymer made up of repeating units that are derived from tyrosine. Tyrosine is first converted into a molecule called dopaquinone by an enzyme called tyrosinase, and then molecules of dopaquinone are linked together to form a polymer that is melanin. When you are deficient in melanin, you have a condition called oculocutaneous albinism. This most commonly occurs when children are born deficient in the enzyme tyrosinase that I showed you on the last slide, which is used to synthesize dopaquinone, which then goes on to become melanin. This is called OCA type 1. There is another version of oculocutaneous albinism called OCA type 2, where children are deficient in tyrosine transporters. In both cases, they have decreased or absent melanin, and therefore they will be born with pale skin, blonde hair, and blue eyes. And this is a picture of a child with albinism. The problem with this disorder is that there is an increased risk of sunburns without having melanin in the skin, and there's a very high risk of skin cancer in children who have albinism. There is a rare immunodeficiency syndrome called Shediac-Higashi syndrome that results from dysfunctional lymphocytes like the one I've shown on the screen here. Shediac-Higashi is a microtubular dysfunction syndrome, and when the microtubules don't work, the lymphocytes cannot respond to infection, and there is a characteristic immunodeficiency that occurs. And I talk about this in the immunology modules in more detail, but the point I want to make here is that children with Shediac-Higashi syndrome also have oculocutaneous albinism. They have the type 2 OCA because they have a transporter defect, because the microtubules are dysfunctional and therefore they cannot transport melanin normally. In addition, there is a rare variant of oculocutaneous albinism called ocular albinism, where there are blue eyes only without the pale skin and the blonde hair. Now let's talk about how tyrosine can be broken down inside of cells in the body. Tyrosine can be metabolized to a molecule called homogentisic acid, or HGA, and then there is an enzyme called homogentisic acid oxidase which can convert HGA into fumarate and acetoacetate. Fumarate can enter the TCA cycle and become glucose, and therefore tyrosine is a glucogenic amino acid. In addition, acetoacetate is a ketone body, and therefore tyrosine is both glucogenic and ketogenic. And this is a good way to remember that tyrosine and therefore phenylalanine, which it comes from, are both ketogenic and glucogenic amino acids. If you are born with a deficiency of the enzyme homogentisic acid oxidase, you will develop a condition known as alkaptonuria. This is an autosomal recessive condition that results from high levels of homogentisic acid inside of tissues. The problem with high levels of HGA is that the molecules can polymerize and form a dark pigment. So people with this condition have pigment deposited in connective tissue throughout their body. This is a condition known as achronosis. If we go back one slide, this is the enzyme that is deficient in alkaptonuria, and therefore levels of HGA build up inside of the body and the molecules will polymerize, leading to the formation of dark pigment. A classic finding in children born with alkaptonuria is dark urine when the urine sample is left standing. So if you take a urine sample from a child and it is fresh, it will look yellow as you would expect, but after the sample has been left standing for a while, it will start to turn dark, and that's because those HGA molecules are polymerizing and forming dark pigment inside of the urine sample. The major cause of morbidity in this condition is arthritis. The pigment deposits in large joints like the knees and the hips, and the severe arthritis can be crippling in patients patients with alkaptonuria. There will be black pigment seen on biopsies of their cartilage and their joints. A classic X-ray finding is to see calcification in the intervertebral disc. This is an example of a patient with alkaptonuria and what their discs might look like. The urine discoloration is often seen in infancy. That's the classic finding I described at the top of the slide. The other symptoms, like arthritis, take many years to develop, so it's usually in the 20s to 30s when patients start to get arthritis and limitations from those symptoms. You can diagnose alkaptonuria by finding elevated levels of homogentisic acid in the urine or the plasma, and one of the treatments is dietary restriction of tyrosine and phenylalanine because those amino acids are metabolized into HGA, and this is the kind of thing they like you to know for step 1 because they like to test whether you understand the underlying biochemistry. I'll finish this module by discussing the breakdown of catecholamines like norepinephrine and epinephrine. You should know that dopamine and norepinephrine and epinephrine are often called monoamines because their molecules contain a single amine group. If we go back to this slide, you can see that dopamine has a single amine group, so does norepinephrine, and so does epinephrine, and hence all three are called monoamines. These monoamines are degraded by two enzymes. The first one is called monoamine oxidase. It converts the amine group into a COOH group. I'll show you a picture of that on the next slide. And the second enzyme is called catechol O-methyltransferase, or COMT. It transfers a methyl group to one of the oxygens. Epinephrine and norepinephrine are ultimately degraded to a molecule called vanillomandylic acid, or VMA. Dopamine, on the other hand, is degraded to a molecule called homovanillic acid, or HVA, and then HVA and VMA can both be excreted in the urine. And both of these molecules have the word vanilla in their name, and that's always seemed very strange to me and made it easy for me to remember that. Here's how dopamine is metabolized into HVA. Both MAO and COMT need to metabolize dopamine to convert it to HVA, but they can metabolize it in either order. If MAO goes first, it will convert the amine group into a carboxylic acid group, and then COMT, which is a methyl transferase, will add a methyl to one of the oxygens. If COMT goes first, the process is simply reversed. This slide shows how norepinephrine and epinephrine are metabolized into VMA. Once again, MAO and COMT both need to metabolize the molecules, but they can go in either order. If COMT metabolizes them first, structures called metanephrines will be created. These are either normetanephrine or metanephrine, and MAO can then convert those molecules into VMA. If MAO goes first, it will create an intermediate called dihydroxymandelic acid, which COMT can then convert into vanillomandylic acid, or VMA. There's an important clinical correlation of these pathways, and that involves pheochromocytoma. Pheochromocytomas are tumors that generate catecholamines, and the majority of the metabolism of the catecholamines occurs inside the tumor. Therefore, lots of metabolites of catecholamines will be secreted into the plasma, and metanephrines are often measured for diagnosis. Usually you measure metanephrine and normetanephrine levels via a 24-hour urine collection. There was an older test that's not done that much anymore because it's less sensitive, and that was a 24-hour collection of VMA. And after the last two slides, you can now understand why measuring metanephrine levels or VMA levels in the urine will help you diagnose high levels of catecholamine turnover, as you would see in pheochromocytoma. There's some pharmacology that involves the MAO and COMT enzymes. In Parkinson's disease, there is a drug called selegiline, which is an MAO-B inhibitor. There are also two Parkinson drugs called entacapone and tolcapone, which are COMT inhibitors. And all three of these drugs are administered to patients with Parkinson's disease to blunt dopamine breakdown and raise dopamine levels in the basal ganglia of patients with Parkinson's. In depression, there are some older antidepressants that are not used much anymore called MAO inhibitors. These are drugs like tranylcypromine and phenelzine, and they inhibit the MAO enzyme to raise dopamine and norepinephrine levels in the central nervous system. They also raise serotonin levels because, as we will see in another module, serotonin is also metabolized via the MAO enzyme. The last topic I'll discuss in this module is tyramine. Tyramine is a naturally occurring substance that is found in many of the foods that we eat. Tyramine is a sympathomimetic, meaning it causes activation of the sympathetic nervous system. This is the structure of tyramine at the top of the screen here. You can see that it has a very similar structure to dopamine, so it's easy to understand how tyramine could have many of the same effects as dopamine. And in fact, it's been shown that tyramine is taken up by presynaptic nerve terminals, and it induces the release of norepinephrine and therefore can raise the blood pressure. Now, normally when you eat foods that contain tyramine, they are metabolized in the GI tract. However, they are metabolized by the monoamine oxidase enzyme. Therefore, patients on MAO inhibitors can see the level of tyramine rise in their blood. This can raise the blood pressure and, in fact, can cause a hypertensive crisis. This is sometimes referred to as the cheese effect because tyramine is found in cheese and also in red wine and some meats. So patients on MAO inhibitors, especially the ones used for depression, who go out and have a big pizza dinner can find that they are in the emergency room with a headache from a hypertensive crisis. And that concludes our module on phenylalanine and tyrosine.